All right, so we are getting started. Welcome to everybody who is tuning in to an EBFA webinar. If this is your first time as part of EBFA's webinars, very special welcome. My name is Dr. Splickle. I'm the founder of EBFA. If you are a return supporter of EBFA and part of our education, then very special welcome to you as well. We have a very special guest on today's and all of these webinars that we are doing over the next 6 weeks are in association with the Barefoot Strong Summit that is coming up October 26th, 27th in Arizona, as well as online access. We'll have more information on that shortly. Before we get into the actual webinar, a few business matters. Is one, all of our webinars are recorded, they are archived, so just in case if you want to re-listen or share this webinar or you get disconnected, have to leave the webinar, do not worry, they are recorded. You can find all of the webinars on the EBFA YouTube channel, which is youtube.com/EBFA Fitness. This will be there as well as any of our past webinars. After we go through the webinar, we will go through any questions. So if you have questions throughout, please type those in the control panel. If you scroll down, you will see that halfway down the questions tab, just type those in and we'll make sure that we get to those. If you have to leave before you get your question answered, we will have our presenters' information at the end. So we are ready to jump into a very special webinar that we have today. Our guest is a very good friend of mine and actually was my doula during my birth. She was an incredible resource leading up to my birth, and then throughout the birth, she was an invaluable part of my birthing process. So she has some very great information for all of the listeners today, and it is an honor to have Chantal be our presenter. Welcome, Chantal.
Thank you, Emily. I'm so excited and honored to be here.
Perfect. I'm going to pass it over to you. I'm going to step to the side, and I hope that everyone enjoys the webinar.
Thank you. Hi, everyone. I'm Chantal Traub, and I'm an active birth doula, childbirth educator, yoga teacher, and Mutu systems trainer specializing in prenatal and postpartum preparation, birth through recovery. I've been assisting expecting families in New York City for 17 years. I'm aware that there are pregnant people that identify in a variety of ways, and for this webinar, I may refer to the pregnant person as mother, she, her, and I mean no disrespect by this language. What I've noticed from going to hundreds and hundreds of births is that women are often underprepared for the pushing part of labor. It's not always as intuitive as we imagine it to be, and it may be confusing which muscles to engage or which to release or which direction to go in. Women often push into their faces, creating broken blood vessels, or into their abdomens, causing a diastasis, or if they already have one, making it worse, or inefficiently pushing for hours, often creating unnecessary stress and damage to the perineum, and may end up with an episiotomy, vacuum, forceps, or even a cesarean birth. Pushing is often the shortest time in labor, but if things go wrong, it has such long-lasting repercussions. When I've brought this up over the years with various midwives or OBs, the answer I'd often get was, well, women figure it out while doing it, and they only have to do it once because pushing is so much easier the second time. And I would think, yes, that may be true, but not always. Some of my older students would tell me that they leak when they jump or sneeze, have ongoing back pain or pelvic pain, or even a prolapse. They who had their children many years ago. And what I came to realize is that as we age, our bodies go through a lot of changes, and often these obstetric events of the past may catch up with us. We don't tend to think about our pelvic floor, but when something's wrong, that's all we can think about. I kept thinking that there's got to be a better way to prepare these women. This is what pushed me to create my Pushing Power workshops. I want to help women to prepare ahead of time to push effectively and protect the pelvic floor for a meaningful and positive birth experience. I had a client who hired me for a VBAC, a vaginal birth after C-section. And as we got closer to her due date, her OBs wanted to schedule a repeat cesarean. And even though she accepted this idea, it just really bothered her. She had prepared so hard in advance for an optimal chance for VBAC. And it just really niggled at her. And she kept calling me and saying, I just really wish I had this chance, just one chance to try again. So I said to her, if you go into labor, would they stop your labor and give you a C-section, or will they let you labor? And she was like, I don't know. That's a good question. I'll ask. And she got back to me and she said they didn't think she'd go into labor by the time her C-section was scheduled. But if she went into labor, they wouldn't stop her. They would give her a chance. So I said to her, when you go in on the Friday, and her C-section was scheduled for a Tuesday, I said, why don't you get checked? And if your cervix is favorable, we'll, make some suggestions. And she went in and her cervix was not favorable. So I suggested, why don't you chill out this weekend? And then when you go into your pre-ops on the Monday, see if you can go back in, get checked. And if there's significant change to the cervix, then we'll give it a shot. So she went in on the Monday and her cervix was in fact changed completely. And so she ran it by doctors again, were they on the same page with her trying to get herself into labor? And they were like, great, go for it. We don't think it'll work. We'll probably see you on Tuesday, bright and early. So she called me and said, let's go. What should we do? So I made some suggestions. And lo and behold, that evening I get a call and she's in labor. So I said, great, I'm coming right over and we're going to go in, call your doctors and let them know that we're coming into the hospital. So I got to her home and she was like, why do I have to go in? It took so long the first time. So I reminded her that the first time she labored to 10 centimeters, pushed for a while before having a cesarean birth. So this time, because this was at 38 weeks, the baby was still quite small. And I just intuned that it was going to go a lot faster, more like a second time labor. So we head into the hospital. And when we get there, of course, the OBs weren't there. And it was just very kind of low key and a little slow. And she's standing over a railing, leaning over and just breathing through her contractions. And I kept saying to the staff, heads up, this labor's going to turn. We got to get a room. Anyway, finally, we get into a room and now she's leaning over the bed, breathing through her contractions in a very contained way. And suddenly she's like, oh, I think I feel my baby coming. So I was like, that's great. Let's get checked. Maybe it's time to push. And they were like, no, we're not going to check you. Your providers aren't here yet. Anyway, she's breathing through her contractions. And then another big one comes and she goes, oh, I really think I feel my baby coming. What should I do? So I said, well, don't force anything, but trust your body. Just go into it. Don't hold back. Remember what you learned in class and just relax your pelvic floor. And they were like, no, don't push. We need to get you on the bed. So she's breathing through a few more contractions. And then another big one comes and she goes, oh, I feel my baby coming. I've got to push. And they were like, no, don't push. And suddenly a young attendant comes running in and says, don't push. We need to go back for a C-section right now. And you don't have an epidural, so we're going to give you general anesthesia. So she looked at me like, what? And I was like, okay, trust your body. Just go with it. Don't force anything, but don't hold back. Really trust your body, what you need to do. So they start pulling wires out of the wall and kind of getting the bed ready and start rushing out of the room towards the operating rooms with her poor bewildered husband and myself running right behind her. And they go into the operating room and they close the doors. And we're pressed now to those little small windows. And I'm hearing, oh, and we hear, no, you really shouldn't push. And she's like, gah. And then I see someone lowering an oxygen mask to her face as they set up for general anesthesia. And so I'm just yelling through the doors, don't hold back, go for it, give everything you've got. Just remember what you did in class, go for it. And we hear another big, oh. And then we hear a baby cry. So no general anesthesia, no C-section. Her husband's crying, I'm sweating. And when we meet up in the recovery room after, she says to me, it wasn't the calm, peaceful birth experience that I was hoping for, But I'm so thrilled. I knew what to do. I knew to trust my body. I knew not to fight those surges. And I knew how to relax my pelvic floor to let my baby out. So sometimes learning what to do ahead of time to help your baby out is essential. It may make a big difference to your birth. In this webinar, I'm going to go over the relationship of the baby and the pelvis and the role of the perineum. We're going to dive deeper to understand what is second stage labor. We'll talk about pushing positions and what can help during pushing to protect the perineum and tips to prepare ahead of time. Firstly, we need to consider the baby. The baby has to travel through a curved tunnel of the pelvis in order to be born vaginally. It has its own sequential reflexes to move through in order to be born. It first has to enter the brim of the pelvis. I put a little number red 1 there so you can see. And now begins to pass through a much narrower funnel. As the baby comes down to the middle of the pelvis, the halfway point, I put a little 2 there, marked by the ischial spines, this is where the deep muscles of the pelvic floor attach. They attach at the back by the sacrum on a level of around S3, S4, in front halfway up by the pubic symphysis and by the 2 ischial spines. And a supple, well-balanced pelvic floor muscles will align the position of the baby's head and assist in the baby's final rotations. The sit bones, mark number 3, mark the outlet, the end of the tunnel, and this is where the perineum is attached. It's also attached at the pubic symphysis and towards the tailbone. The bones of the pelvis are able to move slightly, both against themselves and in relation to each other. And during this movement, the pelvis undergoes small changes in shape. The shape of the pelvis and its adaptability are important in understanding the function of the perineum during birth. Our pelvis also connects our spine to our femur bones. So let's find our own sit bones. Where you're sitting or standing, just place your hands onto your sit bones with your fingers just on inside of the sit bones. And then I want you to lean forward with your spine and just notice the space between your sit bones and the space in the perineum between the sit bones. Just observe. And then lean back as if you're sitting on your tailbone, like lean all the way back. If you're standing, lean back and notice the space between your sit bones. And then bring your spine up to a neutral position. With your legs, bring your knees towards each other and notice the space between your sit bones. Notice if there's any stretch in the perineum, in the posterior part of the perineum. And then bring your legs into an external rotation as if you're going to do a plie, and just notice the space between your sit bones and the tension or space in the posterior part of the pelvic floor. Just observe. It's important to get to know your own pelvis and to find the bony landmarks so that you can learn how to make more room in your pelvis for the baby. At our upcoming summit and in all my classes, we get to explore how the pelvic bones move during delivery and how the head of the baby adapts by turning in much more detail. The pelvis contains and protects the lower abdominal organs. In the female pelvis, they are the bladder, the uterus, and the rectum, and these organs are supported by each other and by the pelvic floor muscles. Our pelvic floor is our most powerful muscle group. We hold a lot of pain and anger and fear in our center, and I encourage you to explore some of this ahead of time before birth. The baby has to navigate not only the bones of the pelvis, but also all the soft tissues and pass through the pelvic floor before it slides across the perineum, crowns, and births. In my classes, we explore how our alignment, our breath, and our daily movement patterns affect our core and pelvic floor, and why that matters for a functional birth and optimal recovery postpartum. I want to share a video with you that shows how the baby has its own sequential reflexes to move through in order to be born.
If the mother's body is in a state of balance and the baby is in the optimal position, effacement, thinning of the cervix, and dilation, opening of the cervix, will be symmetrical. and the baby's head will now pass through the pelvic inlet. Now that active labor has begun, the baby's head will rest upon the mother's oblique pelvic floor muscles, which apply pressure to the side of the baby's head, specifically the temporal plates. As the oblique muscles force the temporal plates to fold together, the baby's neck muscles rotate his head toward his left shoulder and activate the primitive asymmetric tonic neck reflex. This will result in an elevation of the left shoulder, which then reduces the diameter of the upper torso. Ideally, the baby will turn his face toward the curved portion of the mother's sacrum, and the back of his head will line up under her pubic bone. The baby can now slide even further into the birth canal. Once he moves past two bony points inside the mother's pelvis, called the ischial spines, he will continue to turn another 45 degrees until the widest diameter of his head lines up with the widest part of the pelvic outlet, the vaginal opening. As the baby rotates through the birth canal, the contractile forces of the vaginal wall stimulate one side of his spine, which activates the primitive galant reflex. This results in hip flexion and a decrease in the diameter of the lower portion of the baby's torso, allowing the baby's pelvis to slip through the fully dilated cervix. Crowning occurs when the top of the baby's head can be seen at the vaginal opening. As he slides through the opening, pressure from the anal gutter will force his head backward into extension. This will accomplish two things. One, the back of his head can slip under the pubic bone. And two, the primitive Perez reflex will be activated by strong contractile stimulations to the baby's entire spine. Extension of the baby's head will result in extension of the baby's pelvis and legs. That, along with the influence of the Perez reflex, will cause the baby to eliminate any remaining amniotic fluid from the lower urogenital tract. The result is a tight, compact pelvis passing through the birth canal. Extension of the legs and pressure of the uterine wall against the top of the feet will fire another primitive reflex that forces the baby to simulate walking, thus pushing against the top of the uterus. Once his head is out of the canal, the baby must roll his shoulders around so they too can line up with the widest diameter of the vaginal opening. To accomplish this, the mother's oblique pelvic floor muscles apply pressure to the shoulders, turning them until they can slip past the ischial spines. This results in the desired head rotation. As the baby's shoulders roll to line up with the vaginal opening, his neck muscles will slowly turn his head back toward his chest. Once the baby's shoulders are lined up properly, he will proceed to roll his body out of the birth canal. After delivery, the baby will intuitively cry out in vibrant bursts of sound to 1. Restore normal fluid dynamics by forcing cerebral spinal fluid and blood back into the cranium. 2. Force air into the lungs to initiate breathing. And 3. To initiate a proper rhythm within the craniosacral system.
Second stage labor is defined as the time from the cervix is fully dilated until the birth of the baby. And it may take a few minutes to a few hours, especially in a first vaginal birth. And this is all in the range of normal. But just because we're 10 centimeters, does that mean that you're ready to push? There are two phases to second stage labor. There is being 10 centimeters without or before strong contractions. The contractions may space out temporarily around the time of full dilation because sometimes as the baby comes down, the uterus has to now adjust and tighten up around the baby before it sends much stronger expulsive contractions. The baby might need to complete some of its head rotations in order to come underneath the pelvic bone before it starts stronger contractions. And so why not wait and rest? Why not change positions? This is a great opportunity if everything's going well with the mom and with the baby. Why not let her have a nap or rest for a while? This is a great opportunity to get into water if you have access to water, like a shower or a tub. Or if you have an epidural, to try different positions to encourage the baby to rotate. So I always like to say when you want to move the baby move the mother. The active, more participatory phase is when we like to say there's hair on the perineum. The baby is visible. It's really low down. Or there are strong expulsive contractions and the cervix is 10 centimeters, or signs of showing 10 centimeters, or an active effort, a participatory effort of the mother and being 10 centimeters, but without expulsive contractions. So there's no reason to start pushing until the baby is so low down that you see baby's hair on the perineum. Of course, this is case by case, and both mom and baby have to be okay to wait. And there are different styles and different philosophies. But if it's a long descent and there are no contractions, why not wait until the baby is lower? Or if there's an epidural, why not wait until the baby labors down, if you will? We want to explore different positions to help work with the baby to help it descend and rotate through the pelvis. Upright positions like standing, leaning forward, kneeling, and squatting work with gravity to help drive the baby down. And the mom should choose positions that she feels comfortable in, using gravity as long as it doesn't tighten up the muscles to hold the position. I had a client who was having an instinctive physiological birth. So she didn't have an epidural, and now she was pushing. And she was pushing in a traditional C-curve position that she was quite happy being in. And as the baby descended, its heart rate went down. So her OB said to her, I know you don't want an episiotomy, but if this baby's not born in the next few pushes, I'm going to have to cut you. I'm really sorry. So I quickly said to the OB, who I actually had a good relationship with, I said, can I just have the next few pushes with my client? And she was, yes, of course. How can I help? So I said, let's turn her onto her side. So I said to my client, come, let's turn you onto your side. And she was like, I can't move. I have a bowling ball down there. And that's what it sometimes feels like when the baby is so low down, you can't move. So we both actually picked her up and over all the way onto her left side. So she was almost towards her tummy with her right knee up and over. And on the next contraction, her baby rotated. And on the next contraction, her baby rotated some more. And on the next contraction, her baby crowned and birthed with an intact perineum. So no episiotomy, no cuts, no tears. So the position that you choose to birth in can have a direct impact on your perineum. And the provider you choose plays a big part in protecting your perineum. We often underestimate how much work it is and how much work it takes to help the baby down and out. If one has an epidural or can't feel where to push, learning ahead of time which muscles to engage and which ones to release so that you can visualize it and think it until there's more pressure, that you feel more pressure is really important. If the mother's progressing well, we'll support her physiological push-in. But if she's pushing ineffectively, then we can offer more direction. But if the baby needs to be born imminently, then we offer strong directed push-in. In upright positions, gravity can help the baby move down. A squatting position increases the size of the pelvis, but can also be more tiring. And side lying, hands and knees, and semi-sit-in is more restful. The perineum needs time, just like the cervix, to soften and thin and efface and stretch around the baby. And now that the baby has come down underneath the pubic arch and begins to slide across the perineum, it's time to yield and breathe and blow the baby out. If the mother doesn't have an epidural, she may often feel a burning sensation, and this is her cue to slow down, blow itty-bitty birthday candles, and ease the baby out. If they have an epidural, then to follow directions to slow down and pant or blow the baby out. During pushing, the muscle tissue of the pelvic floor will give as far as it needs to, and sometimes this results in a tear, which eventually heals, but could subsequently contract or atrophy due to the trauma and cause problems later in life. So slow birth of the baby's head. As the baby crowns, you want to blow, breathe, gently pant, sigh, or sing, laugh, or cough the baby out. So there's two parts to push in. There's the direct descent of the baby, and sometimes we have to work really hard to help the baby down. And then as the baby comes underneath the pubic bone, that's when we want to yield and slow down and relax the whole bowl of pelvis, the lower legs, and all the muscles that connect up into the pelvic floor. I had a client who came to one of my classes, and after class, she told me that she tore so badly the first time that she gave birth and was so traumatized. It took so long to heal. It took months to heal that she didn't think that she wanted to get pregnant again. Now she was pregnant and she was seriously thinking about scheduling a cesarean birth. But she heard about my classes and she decided to come and see what it's about. And after the class, she said that she felt so empowered. She felt like she could give it another go. And so she asked me if I'd help her with her birth. So the first stage of labor was pretty straightforward. It was a second time labor. So that part was easy. But as she was beginning to push, and she was pushing in the traditional C-curve position that we often see in the hospitals, and she was comfortable being in that position. But as she would push, the hospital staff kind of got into gear and they started shouting, take a deep breath in, hold your breath for the count of 1, 2, 3, 4, and so on to 10. So she looked at me and I gave her a nod of encouragement because we had gone over so many different scenarios and how it would go and how to prepare ahead of time. So after the next contraction, she turned to the nurse and said, please don't yell at me. I know when to push. I can feel when to push, and I want to ease my baby out. Please help me ease my baby out. And the whole room got it. It quietened down. It completely toned down. And she was now able to tune into her OB and listen to her OB. And when the next contraction came, she waited for the peak of the contraction and then pushed on her own, self-directed, and her OB was able to say, okay, give me a little more. 1, 2, 3, 4. Okay, great. Ease up. Okay, next contraction came. Okay, give me a little more. Hold it, hold it. Okay, ease up. And together, they worked together to help her ease her baby out. And that baby was born with an intact perineum. So sometimes we have to ask for what we want. We have to understand that the nurses and the doctors are going from room to room to room, just doing what they do every day. And they are often in this kind of take charge moment. And ideally, we want to set those expectations ahead of time, to have these conversations ahead of time. For example, like what is your episiotomy rate, or what positions are you comfortable catching my baby, and what positions can I expect to push in? How do you support my perineum at the birth? Just help slow down the birth of the head. But if you don't get that opportunity, if something's not working for you, try to ask for what you want. Often when I'm with a client in labor, I'll say, is this counting helpful for you? Which will give her a chance to say, yes, it is actually helpful. I find it helpful. Or actually, it's really distracting. Can we be quiet for the next push? So being able to ask for what you want is really important. Women following their own urge to push usually will wait for each contraction to build and then push for about 5 seconds or so. Take a few short breaths and then push again. So developing a breath awareness as a daily practice is really beneficial. If you can take a few minutes every day to practice mindful breathing or pelvic breathing, it will help you so much in terms of tuning into your own body in birth. There's not one way to breathe for push-in, and women breathe in a variety of ways. If you have an epidural block, or it's a long descent, or if one's own direction of pushing is not effective, then whether you exhale, push, or breath and hold, or a combination of both, it doesn't really matter as long as you wait for the peak of the contraction and then use your abdominal muscles to support your uterus as you relax the pelvic floor, driving the head of the baby down. As the baby crowns, you want to pant or blow. But what about sounding? What about singing, arming, making low ah sounds? I want to really try and drop the jaw and allow the vibration of the sound in our throat to vibrate with our pelvis. So you can explore making sounds with an open glottis and notice how that feels. So if you were sitting on your hand on your perineum and you made sound, notice if you make a deep sound, that vibration on the perineum, or if you made a scared, tight sound, what happens to your perineum? We want to let go of all control, open our throat, drop our jaw, and connect to that vibration. Even if we close our mouth and don't let the sound out, you want to keep your throat open. You don't want to tighten in your throat. Or no pushing. So as the perineum stretches and opens around the baby, we want to yield and let that baby ooze out. I always remind my clients of the 4 Ps: open glottis, open throat, and patience. We want patience to allow that perineum to soften and efface and thin out and stretch around the baby's head. And then no pushing as the baby crowns. The benefits of effective pushing are delayed or spontaneous bearing down, more intact perineums, spontaneous births, fewer 3rd and 4th degree tears, and a full expression of the baby's primitive reflexes. So just a reminder to think about the baby's perspective. What does the baby need? How can we support the mother to be calm and relaxed enough to be able to tune into her own body's movements, to be able to sense how to move her body to help the baby move? We want to practice stabilizing and balancing the pelvis. So to practice exercises that strengthen and balance. And I'm a huge advocate for cranial sacral workers, fascial work, pelvic floor physical therapists, because they are experts at assessing pelvic floor for tone and coordination, tension, strength, ability to relax, the pelvic floor's endurance and tightness. So it's worth having, if you feel in any type of pain or discomfort, to seek out a pelvic floor physical therapist in your neighborhood. Often when I'm doing my intakes with my clients and I know that they've either fallen downstairs a lot as a child or fallen on the ice rink or fallen off a horse, I'll encourage them to see someone who will work with that kind of muscles and tissues. Like cranial sacral workers are really great with that, as well as pelvic floor physical therapists, just to see if there's some immobility around the tailbone to be able to release some of that ahead of time for birth. Developing a breathing practice, as I mentioned, or meditation while you're still pregnant is really helpful for being able to relax on a really deep level. And it doesn't have to be hours. Taking 10 minutes a day to sit and breathe, or even lie down where there's no gravity and just breathe into your pelvis, connecting your breath to your diaphragm and allowing that breath to really filter into the pelvis so that you can feel that expansion when you inhale in the pelvic floor and allow it to come to neutral, is really helpful. Whether it's a practice of prayer or quiet time or journaling or walking barefoot in nature, finding ways to come to a deep relaxation, hypnotherapy, or finding ways to develop self-hypnosis can be really helpful in birth. I also encourage you to try positions where you can find length in the perineum and maybe hold those positions and breathe there to feel the opening and the flowering of the pelvic floor. High levels of stress, fear, and anxiety can cause the muscles to reflexively tighten. So we want to know how we can relax and release and lengthen those muscles. And visualize the pelvic floor. Some of our emotions can affect our labor, like the effects of fear and distress. Excessive catecholamines counteract the beneficial effects of endorphins and oxytocin. And as I mentioned, we hold a lot of tension and trauma, grief in our pelvis and our pelvic floor. And it's important to do the work necessary ahead of time to birth, to release some of that. You want to, for your birth room, create a calm, quiet, safe place to birth in so that you can really open up, feel supported, and let go. Ways that you can practice at home is to be in positions, whether you're in the bathroom, you can practice inhaling to release, exhale, sense that blossom, that bulge of the perineum down. You could try sitting backwards on the toilet and notice how that feels. Or sitting on the toilet when you're going to the bathroom and try counting backwards and notice what that does on the pelvic floor. Or sing or make sound or talk while bulging down and notice if you can do that. We want to practice allowing our perineum to release and bloom. So if you notice that you're not able to do that, then you know that you have some work ahead of time. And you can try that. You can sit on the perineum and with your hand between your two sit bones. If you place your hands on your sit bones with your fingers just inside of your sit bones, and you want to practice inhaling to expand, and then exhale, you want to engage your abdominal muscles gently, or hug your baby and think about puffing down towards your fingers and notice if you're able to sense that release, sense that blossom, that bulge. If that's hard for you, then you know that you have to practice. So many times I'm at births, and as my client is pushing down, I actually see her contract up. And then I have to find a lot of ways to help her connect to that release. And sometimes it's making just some slight adjustments in her positions that she can feel that bulge, that release more. So ahead of time, you want to try different positions where you know that you can feel that release a little easier. So practice allowing your perineum to release and open. In this image, I have my heels up on the mat because squatting with the heels up actually allows for more expansion of the posterior perineum. Food is one of the most important regulators of hormones that you have to access every day, and making nutrient-dense food choices and maintaining a healthy lifestyle help both mom and baby. It's so important to keep the big picture in mind. No matter which way your baby comes, it puts you on the other side of birth and at a new beginning in life. Enjoy your baby. Thank you very much for joining me this evening. In the session that I'm presenting at this year's Barefoot Strong Summit, I'll be diving deeper into how to help your clients push safely and effectively, and how to train and prepare the body ahead of time for birth. And I'll include how to screen, assess, and support and rehab the postpartum body. We're now open for some questions.
Thank you so much, Chantal. So if anyone has any questions for Chantal, please type those in. We'll give you a few minutes. And as Chantal had shared her contact information, so please do.
Yeah, I'll go back there. I'll just say, yeah, if any of the questions don't get answered tonight, you can send them to me, but you could also welcome to join my Facebook group, Push Power Community, and ask your questions in there, and I'll answer them.
Perfect. Yeah, so sometimes it can be a lot of information and people just want to let it process, and then the questions come. But while people are thinking of any questions that they might have, Chantal, I have a question, or maybe just some tips that you can give to the listeners of questions that they could ask their clients who maybe had given birth, several years ago, so they're not in that active phase, but some questions about their birth process that can help them to understand their potential pelvic floor health or condition?
Yeah, absolutely. Some of the questions that one can ask is, well, firstly, how did the birth go? Because I think hearing our clients' stories is really helpful in the healing process. So giving them an opportunity to talk about how it went, I think is essential. Of course, to ask, what position was your baby in when you pushed? Did you push out an 8-pound posterior baby for many hours? I mean, that would make a huge difference to the pelvic floor. Was it a very fast delivery? Was it, how many hours did it take? You could ask, if there was a tear, what kind of tear, if they have the information of that, or if there was an episiotomy. Questions like if there was any assistance in terms of vacuum or forceps, or if they were aware if anybody really pushed down forcefully onto the fundus when they were helping the baby birth. Those would be questions that I think could ask, but really what are some of the symptoms that they're feeling now? Because often there may be some symptoms in the early postpartum period, and I know you mentioned like 7 years down the line, but sometimes in the early postpartum period that may just take time to go away. If you're still breastfeeding, for example, there's still that drop in estrogen, so that may still have effect on some of the symptoms. So you kind of want to wait until you're after breastfeeding or a few months down the line. But later, if you've pushed forcefully, into the pelvic floor for long periods of time, that can affect the muscle weakness. It can also affect muscle relaxation. So if someone's been directed to push, like the counting to 10 and holding your breath, even if you run out of air and even if you don't have contractions, that can affect the pelvic floor ability to connect, to relaxing or working synergistically, and we have to be able to kind of reconnect to those messages in the body. Because sometimes when you push, there's a way to contract the muscles, and that can also put a lot of pressure on the pelvic floor later in life. We know that for pushing forcefully for hours can have risk for prolapse later in life.
Now, what would be considered a long pushing duration?
Well, everybody's different, right? Everybody's body can handle pushing differently, like in terms of the muscle integrity. Like everybody, I've seen so many is different. Some people can push really hard and long and not notice and maybe not tear. Later on in life, I think if you're holding your breath, I mean, the evidence is if you hold your breath for longer than say 8 seconds consistently. So if you're pushing from 1 to 10 forcefully without contractions, right, without pressure for hours, that can put a lot of stress on the pelvic floor. But if you're pushing either because you're feeling pressure or you're having the contraction, but you're tuning in more towards your own urge, that you'll push at the peak of the contraction, so maybe you're holding for 5 or 7 seconds, that may be less stress on the pelvic floor. Okay. So, we don't really want to push for hours and hours and hours, even though pushing for hours the first time, 3 hours is in the range of normal. Ideally, we want the baby to descend much lower before we start pushing. Because if you push with a blocked inhalation, it can also be misdirected down, because when you push in with the uterus is closest to the baby, so it's directing the push more effectively. If you don't have the uterus to work with and you're just working with your breath, you can often push more forcefully down into the rectum or down into the central tendon of the pelvic floor. So when you're pushing, you are descending the baby down, but you're actually moving down and slightly forward, almost like in a J curve. So if you don't have the cues with your own body, then you're misdirecting some of that, and it can lead to a tear in the cervix or in the ligaments of the pelvic floor, not just the superficial muscles of the pelvic floor.
Okay, excellent. So Chantal is going to be speaking at the Barefoot Strong Summit Pelvic Balance, which is the day 2, as I had mentioned in the beginning. Again, it's going to be in person in Scottsdale. It's also online. We have a great lineup of presenters that are all speaking synergistic topics. One kind of blends into the other. We are also speaking about male pelvic floor, coccydynia, anterior pubic joint, and then Chantal will be doing a very good review of pelvic floor anatomy that we can tie into the other sessions. Chantal, if you don't mind going forward to the next slide. And then
Yep, let's go.
One last question before we wrap up is related to the psoas. So if the psoas is tight, how have you seen that affects either the descent of the baby or the birthing process?
Yeah, that's a great question. Yeah, sometimes the psoas is just the thing that can hold up the labor. We often say that the psoas is the guidelines for the baby to follow down and out. A very tight psoas can definitely impede the labor. Yeah, so yes, you can see it in different ways for sure. So definitely trying to get in there and release the psoas and lengthen it and release any tightness ahead of time is essential. Sometimes during labor you can do some psoas release work, but I really feel it helpful during the pregnancy.
Are there any other muscles similar to the psoas, obviously outside of the pelvic floor, that you've seen slow labor or the birthing process?
Yeah, absolutely. So the adductors as well is one for sure. In fact, I was just at a birth really recently, and my client was an athlete, and she did a lot of work. But as she was pushing, every time she pushed, her adductors would really tighten up, and I could see her just holding her baby in. And even though I was like massaging like her inner thighs, like really let go, she would let go, and then the surge would come, and she would tighten up. So finally, like she was able to really like tune in and be able to release that. But I think the more that you can work in releasing those inner thighs all the way up into the pelvic floor, and it's interesting because when you get pregnant, and I've taught yoga since 1996 and for many, many years. And I remember as a young prenatal yoga teacher, I'd go, oh, the inner thighs get weak during pregnancy. We have to tighten them. And I'd have my clients squeeze blocks and do everything to tighten those adductors. And one day I was at a birth and it just hit me. I was like, oh my God, what are we doing? There's a reason why the body wants to prepare ahead of time to really kind of like, in a way, weaken those pelvic floors, but to release them so that you're able to let the baby out. So stretching, there's a pose that you can do where it's almost like I think it's called like a check, where you stretch the one side of the inside of the thigh and then move over to the other side. If you have any pubic symphysis issues, then I would be careful with that and do that more seated and as opposed to stretching like up on your heels. But you can also, if you don't have any pubic bone issues, then you could come into like a straddle position would be great as well, where you connect up into the pelvic floor. Those muscles I think are really important. I mean, they really all are. I feel like a lot of the spinning and the bar classes, all that tightening and lifting can definitely impact being able to release the pelvic floor, especially in order to let out a baby. It's great for after the baby and postpartum, but we want to be mindful about what we're doing in terms of letting the baby down and out. And my work, I don't know where all these listeners are, but my work is particularly with New Yorkers. So I'm working with New Yorkers or people that are living in New York and kind of are adapt to a New York lifestyle. And we're very good at like being on the go and drawing in and up and holding ourselves up. But it's much harder for us to be able to let go and release. And whatever we can do, certainly in the last stage of pregnancy, in the third trimester, I would really work on doing a lot of release work, where it's the glutes or the piriformis or the obturator to really get in there and release actually into all those coccygeal muscles. At the summit, we're going to go over a lot of mobility and release work to try and get into all those muscles to be able to, so that you can help your clients for releasing for birth.
Yeah, and I think that's the perfect takeaway point, is making sure that there's release work and relaxation of the pelvic floor and pelvic muscles for birth. Just as fitness and movement professionals, we often think that throughout pregnancy you need to strengthen those muscles so that you're able to support your pelvis during pregnancy, and obviously not have complications after, not realizing that these soon-to-be mamas might be actually creating a delay in their birth or a more complicated situation because they're not training their body to relax. So definitely a huge takeaway, and we'll be going over those and the other release techniques at the summit. Thank you to everyone who's tuned in. Thank you so much, Chantal, for your time and for your information. Really, really appreciate it.
My pleasure. It's a pleasure being here. Thank you, everybody, for joining. And don't hesitate to send me your questions. I'm always happy to answer questions. Those were a couple of good questions. Thank you.
Of course, wonderful. Thank you, everyone. And we are signing off. Please check out the recording. And if you have not signed up for next week's webinar, that will be with me. I will be speaking about the gut-brain axis, gut-brain connection, and how the microbiome can modify your mood. I hope to see you all on next week. Have a great night or a great day, depending where in the world you are. Take care.